We're going to break our lecture on dementia into two lectures, and we'll spend this lecture talking about mainly Alzheimer's dementia and mild cognitive impairment and the pathophysiology underlying Alzheimer's dementia. So dementia is officially called major neurocognitive disorder, although very few people actually use that term. So dementia is still what it's most commonly referred to. So just some terminology to start with of common symptoms that we see in association with dementia. Of course, amnesia is what most families will talk about initially. Of course, that's difficulty learning new information, recalling previously learned information. And we'll discuss how short-term memory, particularly episodic memories, are much more affected as compared to long-term memories. So patients will not be able to tell you what they had for breakfast yesterday, but can tell you great details about things that happened 50, 60 years ago. That's a classic feature for almost all the dementia syndromes. Then we have aphasia, which is not like the aphasias we talked about with stroke. The aphasia in dementia is in parallel with all of the other cognitive deficits. So paraphasic errors are quite common. Remember, that can be a word that doesn't exist, like the grass is greel, or it can be a word that exists, but it's used in the wrong context. So that's common. The vocabulary in general just shrinks in patients that have dementia. Apraxia, we talked about last year, is a loss of the motor programs for previously learned tasks. Recall that we have thousands, tens of thousands of these motor programs for everything that we do throughout the day, for dressing, for brushing your teeth, eating, driving, all these kinds of things. And as we have just a general atrophy of the brain, these motor programs break down. And so patients in an advanced dementia will just forget how to use the toothbrush. And so maybe at an earlier stage it would be more difficulty using things like the remote control for a TV, something like that. So remember, apraxia by definition, the difficulty is not because the patient is weak or they have ataxia or sensory loss. It's rather a breakdown of the motor program. So there's no weakness involved. That's not why the hand can't manipulate the remote control on the TV. It's a breakdown of motor programs. An agnosia is a problem, think of it more of a sensory, not sensory loss, but to process sensory information. And so patients can have a visual agnosia where they just are not as good identifying things. Someone used to be really good identifying all the different types of cars, and now they can't do that as well. Prosopagnosia, we'll talk about in more detail in the stroke lecture, but this is an inability to recognize faces. So patients with Alzheimer's will have more difficulty with that, and also just can't recall the name of the person, when even if perhaps they do recognize the face. Time agnosia is actually quite common, where patients have difficulty just with the sequencing of time throughout the day. Of course, alexia can also be quite common, and phonagnosia is just the difficulty in recognizing perhaps a familiar voice, and they sound less familiar to patients. So we have the 4 A's: amnesia, aphasia, apraxia, and agnosia. And patients with dementia also have dysfunction of executive abilities. And so these are the higher level cognitive abilities involved in planning, organizing, sequencing, abstraction, and later on in the lecture I'll give some specific examples of these. So first let's talk a little bit about mild cognitive impairment. So these are individuals that are having some cognitive issues, so they're at risk, but they don't it's not bad enough that we could officially diagnose the patient as having Alzheimer's or some other dementia syndrome. So you can see this is fairly common, 6.7% between ages 60 to 64, up to 10% once we get up to between age 70 and 74. And so there are two types of mild cognitive impairment, an amnestic and a non-amnestic form. So amnestic, of course, would indicate the memory component. The non-amnestic form would be some other cognitive dysfunction, like a visual spatial difficulty, or perhaps an isolated problem with executive dysfunction, or perhaps word finding difficulty. That would all fit under the umbrella of a non-amnestic form of MCI. And so we know these individuals are at increased risk of dementia. You can see it's above 50% over 5 years, so somewhere between 50 to 80%. So we can kind of think of it as a pre-Alzheimer's form, or at least a high risk for that. And it appears especially high for the amnestic form. So if someone is just coming in with word finding difficulty, they would be at lower risk. Now we do need to remember that just as normal aging, it's common to have word finding difficulty and a little bit of forgetfulness. And so this can be quite difficult to sort out. Are we just dealing with normal aging, or is there something more significant going on? So patients will have this experience, which I had not too long ago. Spent half the day looking for my wallet and keys, and then found them in the refrigerator. And so people, they know individuals, family members perhaps, that have had Alzheimer's dementia, and so they're naturally concerned about that. But a few isolated things like that are common and normal, hopefully. All right, so in terms of workup, we always want to do metabolic testing. We love to diagnose B12 deficiency or hypothyroidism, which can often have a cognitive component, so that would be quite reversible. Most neurologists prefer to do an MRI scan in someone that's having some memory loss to look for atrophy, and we'll see, particularly if you see atrophy of the hippocampus on an MRI scan, that individual does have Alzheimer's, even at an early stage. Or a mass lesion, which we won't find very often, hydrocephalus, for example, or if the patient has had perhaps a lot of small strokes. These are all things that could perhaps explain the memory difficulty the patient is having. So we want to perform baseline cognitive testing, and so a couple of the easy tests can be done in clinic, the MMSE or the MoCA, the Montreal Cognitive Assessment. These can be performed in 5 minutes or so at an initial evaluation, and then can be followed in these patients. We always want to be aware of things that can contribute to memory loss, sleep apnea in particular. So if the patient sleeps poorly at night and the spouse reports, the patient snores and perhaps has apnea episodes, and remember, waking up with a headache in the morning is kind of classic for sleep apnea. And then the patient is just exhausted during the day. So if you're getting those kinds of complaints, you'd want to evaluate for sleep apnea, because that may explain why the patient is having some memory difficulties. In addition, look carefully at the medications that the patient is on. So there are many medications that contribute to memory loss, and I've tried to stick just to the ones that I've mentioned to you so far. So medications that have an anticholinergic properties, like the tricyclic antidepressants, amitriptyline, nortriptyline. So of course these can be used for depression, but remember they're commonly also used for to treat headaches or neuropathy pain, a whole variety of pain syndromes. Incontinence medications like oxybutynin have anticholinergic properties, so that could contribute to memory loss. If someone's taking a scopolamine patch, maybe they're going on a cruise or something like that, that can cause memory loss. And benztropine, remember, we can use these anticholinergics for the tremor of Parkinson's disease, and that would commonly be associated with some memory loss. Recall that anticholinergic medications block the parasympathetic system. And so that would involve salivary glands and would cause a dry mouth, would impair the vagus nerve, stimulation of the GI tract, and would cause constipation, and also urinary retention would be common as well. So we might see those complaints along with patients who are on anticholinergics. Antihistamines like diphenhydramine or Benadryl are often taken for sleep at night, but or sometimes for allergies. But I've seen this quite a bit. If someone is taking this over the counter for sleep, they often will wake up thick-headed and confused in the morning. So that would be an important one to remember. Narcotic or opioid medications that, like oxycodone, for example. So someone's taking that for pain. That will often have a cognitive side effects. Benzodiazepines that can be taken for anxiety or sometimes sleep. So diazepam or Valium would be an example of that. Especially as you get older, these have a more negative effect on the brain and contribute to confusion. So medications for Parkinson's, I already mentioned benztropine, but also the dopamine agonists like pramipexole and ropinirole. And remember, we don't like to use these over the age of 65 because they contribute to confusion. Now I will let psychiatry go over the neuroleptics and antidepressant medications that contribute to confusion, but just as a big category, remember that that can be an issue. And later on, we'll have a lecture on all of the anti-seizure medications, and we'll discuss the ones there that can contribute to memory loss. So those are this is not a comprehensive list, but these are some of the medications that can contribute to memory loss. All right, so in the next lecture, we will go over all of these different conditions. Today's lecture, we're just going to focus on Alzheimer's dementia. And next time, we'll go over all of the mimics and things to consider in our differential. So Alzheimer's disease or Alzheimer's dementia is common, very common. And as a rough guide, we can say that the incidence of Alzheimer's is about 1% at age 60 and then doubles about every 5 years thereafter. So 2% at age 65, 4% at age 70, and so on. So you can see 32% at age 65. It does not continue to go up at that rate. So in the very elderly, over age 90 and 95, we don't continue kind of on that steep incline. But if you look at, this was a study not done too long ago, of 160 individuals who are 93 and older, and only 19 had no memory issues. This doesn't mean they all had Alzheimer's disease, but there were frequently cognitive side effects of medications or other issues that may have been going on in those individuals, and certainly a fair number did have Alzheimer's. Now, if we look at 2019, just appreciate here that under age 65 here in purple, a pretty small slice. And look, only 1% of people at age 60 have Alzheimer's. So if you have someone with memory loss under the age of 60, we really should be thinking of something other than Alzheimer's dementia. But here, over age 75, just notice most of this pie here of Alzheimer's are individuals over the age of 75. So Alzheimer's alone, or in combination with another cause of dementia, accounts for 70 to 75% of all dementia in the United States. So if you just have someone with dementia and you guess Alzheimer's, you will be right, about 75% of the time. Oftentimes, Alzheimer's combines with a vascular dementia. So we often see those two together. So someone has Alzheimer's, but they've also had strokes, and so that's the most frequent combination dementia syndrome. All right, and so just here we are in 2020 with roughly 5.8 million people in this country that have dementia, and we can just see with the growth of individuals over age 85, as the population gets older, that it's projected that we'll almost triple the number of individuals with Alzheimer's by 2050. So there's a significant economic impact, $200 billion cost in 2015. That's only going to go up. And again, that over age 85, fastest growing segment of the population. So let's talk a little bit about the pathogenesis of Alzheimer's dementia. So most cases are sporadic, but yet hereditary genetic factors are important. So if you have 2 or more first-degree relatives, that certainly does increase your risk of getting Alzheimer's disease. So the big picture is that it's this amyloid beta protein, either producing too much or not clearing it as much. That seems to be the underlying factor, most important factor for the development of Alzheimer's disease. So let's start with the amyloid precursor protein. And it's important that you recognize that this is good, healthy. We all have and need amyloid precursor protein, which is very important for the development and stabilization of normal neuronal synapses. So it's important for formation and repair at the synapses. And also recently it's been found that amyloid precursor protein facilitates the efflux of iron. And we know, for example, that there are some genetic causes of Alzheimer's that the prevention of the efflux of iron leads to iron accumulation within the neurons, and then there's some toxicity from that. So that may be important in the understanding of this condition. So the amyloid precursor protein gene is on chromosome 21. Now there is an alpha secretase involved in normal processing of the amyloid precursor protein. And so the abnormal degradation involves the beta and gamma secretase cleavage. And I have a good picture to illustrate this here in a little bit. And so what can happen here is that we get a breakdown to this toxic form, the amyloid beta protein. And so remember, this is what is present in the senile plaques. Remember, those are extracellular. They kind of sit around the neuronal synapses and so cause dysfunction of how neurons communicate with each other. And particularly when the amyloid beta proteins aggregate, and we call this the aggregated amyloid beta protein, that this is the most toxic form of the amyloid beta protein and is most responsible for the synaptic dysfunction. Now, it is very complicated. How is amyloid related to tau? And so I'm not going to go into this. It's not understood very well, but sort of in parallel with this amyloid beta protein formation and aggregation, we also get tau aggregation. But this occurs within the neurons. Okay, so amyloid is extracellular, tau is in the cytoplasm, and so this is what is found in neurofibrillary tangles. It's tau aggregation. And so these neurofibrillary tangles in the cytoplasm cause inflammation, excitotoxicity, mitochondrial dysfunction, and also the neurofibrillary tangles appear to be how the Alzheimer's spreads throughout the brain. So that seems to be more important for spread from one neuron to the next, more so than the amyloid beta proteins. Okay, so normally tau is a microtubular associated protein. It's very important for the function of microtubules. And so as amyloid forms, sort of again in parallel along with this, we have hyperphosphorylation of tau, and that's what leads to these the formation of these neurofibrillary tangles. So here's some nice artwork that a fourth-year medical student, Samantha, completed just recently here to try to remind you that neurofibrillary tangles are here in the cytoplasm. Okay, and so here's trying to illustrate a little bit the microtubules and how the neurofibrillary tangles sort of disrupt the function there, whereas the amyloid plaques are extracellular, okay, sitting around where we should have normal synapses. Okay, and so there are just a few things you have to be able to recognize for step one and for the upcoming in-house exam. What does amyloid look like? and what do neurofibrillary tangles look like. So here's an amyloid plaque, and here are neurofibrillary tangles sort of outlining this neuron. So a few of the known genetic causes, the first that I'll go through are very uncommon and are mainly associated with early onset Alzheimer's dementia. So the amyloid precursor gene on chromosome 21, there are more than 50 known mutations, but altogether these only make up about 10 to 15% of the early onset familial Alzheimer's disease. So really these are quite rare. So mean age is 49, so these tend to be autosomal dominant, so there are lots of known family members. And so the mechanism here of the mutations here are either increased formation of amyloid beta protein or perhaps a more toxic form of the amyloid beta protein. Trisomy 21 or Down syndrome, of course, we have an extra amyloid precursor protein gene. And so individuals with Downs, almost 100% will have Alzheimer's dementia by age 40. Okay, the presenilin-1 gene on chromosome 14 encodes the protein presenilin-1, and so mutations here, we have an early onset familial form of Alzheimer's dementia, and the mechanism appears to be increased abnormal gamma secretase conversion to the amyloid beta protein. Presenilin-2 is probably the same mechanism here involving the gamma secretase. This is on chromosome 1. Then again, we get a more toxic form or perhaps increased of the amyloid beta protein. Okay, so all of those except for Down syndrome would be quite rare. Now this one is really important because it's quite common, and this is associated with the late onset, the more common form of Alzheimer's dementia. And this involves an apolipoprotein. Okay, and so this apolipoprotein is involved in cholesterol, lipoprotein metabolism, normal things, and there are three forms of this, three isoforms, ApoE2, E3, and E4. Almost 80% of individuals have ApoE3. That's the good form. And it's actually protective against Alzheimer's dementia by it facilitates removal of the amyloid beta protein into the bloodstream. The abnormal forms are the ApoE2. If you have that, there's an increased risk of vascular disease. And for our topic, most significantly is the ApoE4. Okay, if you have this form, which is in about 14% of the population, we now have reduced clearance of the amyloid beta protein. Okay, now if you have two ApoE4 alleles, we know that the risk of getting Alzheimer's dementia is 8 to 12 times higher. And so again, these are mainly in the elderly population. Now this has become a big deal because a lot of the common genetics testing that can be done, like 23andMe, and you can send that off, and you can download your genetic profile, and you can see which ApoE form that you have. So I've had a lot of patients come in wanting to talk to me about this. And so it is important to recognize that even though we have an 8 to 12 times increased risk, that this is a susceptibility gene, not a determinative gene. So a determinative gene would be something like Huntington's, where if you have a certain number of trinucleotide repeats, you are going to get Huntington's disease. We could be very confident about that. But if you have even the ApoE4 allele, it's not guaranteed. It puts you at risk, but it's not a guarantee that you will get Alzheimer's dementia. And 40% overall of patients with Alzheimer's don't have the ApoE4 allele. And so these are just kind of important factors, and right now we do not routinely check for ApoE4 alleles in patients. Now, if there were a treatment, something that could be done to prevent the development of Alzheimer's, then obviously all of that would change. So right now it's mainly being done for research and clinical trials, perhaps to determine or create for a study a patient population that is at risk for developing Alzheimer's. So overall the ApoE4 four alleles are found in only 7% of the Chinese population, 15% of Caucasians, and 25% of African Americans. And actually, if you look at risk of Alzheimer's overall, it is lower in the Asian population, and it is somewhat higher in African American population. But even having said that, this is a general statement. If you look at where people come from in Africa, like in the Moroccan population, it's quite low there. It's only 7%, and it would be higher in other areas in Africa. The change from the good to the bad form of this apolipoprotein is very small. It's actually a change in a single amino acid residue here to go from the ApoE3 to the ApoE4. But that results in a significant conformational change here of this protein, but it is quite small. And so here is just looking here at the amyloid precursor protein. And so notice here that we have, here is the amyloid beta peptide. And so we have three enzymes that break this down. Here's the alpha secretase cleavage site, beta, and gamma. Okay, and so normally here we have the alpha cleavage, okay, right here. And so notice that this whole thing here, the amyloid beta protein or peptide, is not intact in that normal cleavage pathway. Okay, and then we get the gamma cleavage, and this form again is not toxic to the neurons. Okay, but if instead we have initial beta cleavage here, notice that we now have an intact amyloid beta peptide. And now we have the gamma cleavage, so again an intact amyloid beta peptide. And so this again, when it aggregates, again especially these amyloid beta aggregates right here, this is what is especially toxic, and this is how we get our amyloid plaques. So again, this contributes to a lot of synaptic dysfunction, contributes to neuronal cell death, and secondarily, through a very complex mechanism, in parallel, we have phosphorylation of tau, which leads them to aggregate and form these neurofibrillary tangles, which again are within the cytoplasm of the neurons. Now, epigenetic factors are very important as well. And actually, as I said, most cases of Alzheimer's are sporadic, not hereditary. And so I am not an expert on epigenetics, but this is really a very big area in medicine in general, and certainly for Alzheimer's. So there's the term epigenetics. Probably most of you know more about this than I do, but it's above genetics. So here's the best definition that I could come up with. Things that have a controlling influence on the body through gene expression. So epigenetics, usually the mechanism is DNA hypermethylation, or there are other mechanisms as well, but it alters how and when certain genes are turned on or off. And so the most important epigenetic factors for Alzheimer's relate to things that would contribute to vascular pathology. So hypercholesterolemia, hypertension, diabetes, obesity. So in other words, these are lifestyle things that have a very real effect on one's risk of developing Alzheimer's. Diet, there are some interesting studies. Certainly diet impacts these four above here, obviously, but that a plant-based diet can actually be quite protective, have at least some effect, protective effect for Alzheimer's. I know the dementia specialist here at Loma Linda recommends a vegetarian diet because of that. And a sedentary lifestyle, likewise, is actually a risk factor for developing Alzheimer's dementia. Most recently, secondhand smoke, air pollution, and exposure to pesticides have all been recognized as well as environmental risk factors for Alzheimer's dementia. And so here's kind of just a nice drawing showing you how these epigenetic factors contribute to age acceleration, the risk of dementia. So smoking is certainly a vascular factor. I didn't have this on my slide, but excessive alcohol intake, again, drives this in the wrong direction. We don't want to accelerate this clock. Poor nutrition, as I mentioned. There are even some studies looking at stress and how that tends to accelerate this whole process. So if we want to decelerate, well, we'll make changes in lifestyle with diet and exercise and smoking cessation and keeping alcohol use at a, sort of a mild quantity. So of all protective things, what we have the best evidence for right now is actually for exercise. So a huge meta-analysis of 16 studies showed a 45% reduction of Alzheimer's for those who are physically active. Okay, so if we want to do something now to lower our risk, it would be regular physical activity. Now, interestingly, there are a number of things that are protective, such as advanced education, speaking multiple languages, and playing a musical instrument. And it may just be that these things are just healthy for the brain because we have greater synaptic density. You learn a language. Think of all the pathways and how all the neurons need to communicate with each other in a different way because of that, or if you learn a musical instrument. But these are healthy things for the brain. Now, in terms of the pathology, we get diffuse atrophy of the brain, especially in the association cortex areas. And microscopically, we just have a dropout of cortical neurons, but especially in the temporal lobe and especially involving the hippocampus. And if we kind of drill down in the hippocampus, the CA1 neurons are especially affected. And remember from our lecture last year, we talked about transient global amnesia and how these individuals, during the few hours where they have their attack, have a significant anterograde amnesia and difficulty with episodic memory. They keep asking questions because they can't lay down any new memories. And so Alzheimer's dementia would be the degenerative condition that would especially affect those CA1 neurons in the hippocampus. We also have a dropout of the neurons that produce acetylcholine. So this is the basal forebrain cholinergic nucleus, otherwise known as the basal nucleus of Maynard. And when we get into treatment of Alzheimer's, we'll talk about enhancing acetylcholine in the brain as something that can help patients a little bit with their memory dysfunction. So remember, senile plaques are extracellular amyloid beta protein, neurofibrillary tangles is tau that is intracellular in the cytoplasm, and the neurofibrillary tangles, it's tau and also ubiquitin. There's another protein that's involved there. So later on we'll list all of the tauopathies in neurology, but for now Alzheimer's is certainly one. And Dr. Deist talked with you about granulovacuolar degeneration of the hippocampal pyramidal cells is something else that would be seen at pathology. So the earliest finding then in Alzheimer's is an anterograde amnesia, especially for episodic memories. And so again, episodic memories are the ones that have a very personal experience. This is where we went to dinner yesterday. This is what I was given, on my last birthday. It's in an episodic memory, you sort of relive the experience. And so patients with Alzheimer's, once they have the onset of symptoms, it's those laying down of new episodic memories is very, very difficult for them. Family members will just say they're just a little bit, just slightly duller in their intellectual faculties. In conversation, they're just a little bit less interesting. They have less to talk about. Okay, because the whole brain is affected in Alzheimer's, working memory is certainly affected. Remember, that is how we hold, process, and manipulate information as we consolidate it. So this is what you're doing in medical school, is you're using working memory all the time. As you add new information, you're trying to process that with things that you already know. And so that's impaired in Alzheimer's. Semantic memory, and remember that's just world knowledge information. That is relatively preserved in Alzheimer's. So the long-term memories, the semantic memories, what's the capital of South Dakota? or what happened in 1950. Those kinds of things are relatively preserved. So again, it's more short-term memory, long-term memory is relatively preserved. And this is very helpful to know, is that in Alzheimer's, even at an early stage, there's a significant loss of insight. And so it usually is the family members that are bringing the patient in, not the patient himself or herself. So the patient will feel like the family is making too much of it, and the family is very concerned, that what is going on. So it's kind of a general rule of thumb. If a patient comes in complaining of memory loss, it's probably not Alzheimer's disease. It's probably something else. So loss of insight, very common. And family members will describe just a loss of interest in activities and hobbies. So I've heard this story many times. The patient used to do a lot of woodworking, and they just kind of lost interest in that, stopped doing it. So remember the 4 A's that are very common in any dementia. So an aphasia, so the vocabulary shrinks, and patients, if you just listen to them talk, instead of, describing the very specific name for something, they'll use the more general term, or sometimes we'll just call it that thing. Ability understanding language is difficult as well. You'll often have to repeat things a few times to patients that you see with Alzheimer's dementia. So apraxia, as I mentioned, just difficulty using basic things. And, so someone has always been able to sew very well, and they just can't, do what they used to be able to do. Can't manipulate the sewing machine like they used to be able to do. And again, in an advanced stage, can't figure out how to use the fork. Just can't figure out how to hold it with their hand. Agnosias, I mentioned, are very common. And the hippocampus we talked about last year is the GPS center of the brain. And so at a very early stage, patients with Alzheimer's get lost more easily. And I usually hear this when driving. So they're going someplace and they take the wrong turn, and they just can't figure out how to get back on the right road. And so in an advanced stage, someone with Alzheimer's will get lost in their home. So here's a very common interaction when I'm doing cognitive testing that I've had with patients that have Alzheimer's dementia. So I'll ask, what year is it? And the patient, they don't have insight. They're trying to downplay, so they'll make jokes maybe, and they'll just say, I'm retired. I don't pay attention to the date. Don't give up. So you say, well, that's okay. Give me your best guess. And so maybe the patient would correctly say 20. But don't stop there. Well, what's the full year? The patient will say 20. And so in order to help them understand, you'll ask, well, what year were you born? And they might say 1941. And so then you can say, yeah, that's the full year. Now, what is the full year now? And the patient, I just had a patient within the last week that said this. Oh, it's 1920. Okay, and so just, again, just don't quite seem to get it there. As things progress, there's impaired judgment and impaired problem-solving abilities. It's frequently helpful to ask who pays the bills. And so you'll often get a story about bills being paid twice, or maybe more often not paid at all, or an extra 0 is added. So that often happens. Superficially, patients with Alzheimer's appear pretty normal until their condition is quite advanced. And so these individuals are usually, outgoing, they're telling jokes, they on a very superficial level can appear normal. But again, just like that interaction I just gave you, when you get into more detailed questions, they actually perform quite poorly. Perseveration is something that's very common in Alzheimer's and many other conditions, where patients will tend to focus in on something and just repeat that over and over. I have a couple of patients that I see with Alzheimer's that every time will tell me at every visit more than 5 times what a good memory they used to have. And they just kind of obsess on that. I have another patient that tells me the same dirty joke each visit, sometimes more than once at the same visit. Or sometimes when you're doing memory testing and you might ask the patient to remember something, they may just remember that same thing over and over and forget everything else. So perseveration is quite common. In a more advanced patient with Alzheimer's, now we get apathy and social withdrawal. Again, tend to be outgoing early on, but then more withdrawn later on. And as the disease advances, we need to remember that mental health issues in Alzheimer's are very common. So depression and anxiety, and in the late stage, agitation, restlessness, delusions, and hallucinations. And these are very distressing for family members. So, and overall, for family members, the behavioral burden of this tends to be more troublesome even than the memory loss. Okay, and in the end stages, we get some features of Parkinsonism. Now the patient has difficulty getting in and out of chairs, they're walking, may shuffle a little bit. So this is not Parkinson's disease. This is Parkinsonism due to advanced Alzheimer's dementia. And on exam, we do want to check for frontal lobe release signs that I mentioned in the neurology exam lecture in patients with Alzheimer's. So the glabellar sign, where you tap on the forehead. And again, patients should normally blink only once or twice. Patients with Alzheimer's may just continue to blink. Or the palmomental reflex, where you scratch the palm and you get wrinkling on the ipsilateral chin. So we do like to check these, and they're associated with frontal lobe pathology. So eventually patients with Alzheimer's are bedbound. They don't know their family members. They're in a vegetative state. Death is usually due to infection of some sort, a pneumonia, bladder infection, something like that. So just practically making the diagnosis, this is a clinical diagnosis. So you're going to get most of your information from family members because the patient doesn't have insight. I do like to ask, when was the patient last normal? Which can be difficult to determine, but we want to know about, when did this start? And so some good practical questions. I already mentioned who takes care of the bills. Well, when was there a change? Why was there a change? Or who prepares the meals and cleans the house? Maybe this individual always did the cooking, and 9 months ago just stopped doing the cooking. That would kind of maybe give you an idea about when things started. Loss of interest in hobbies. If the patient stopped driving, why did they stop driving? And there'll usually be a story there about what happened. So we do want to perform these cognitive tests, the MMSE and the MoCA as mentioned, and we do need to follow those with each visit. But frequently patients will get frustrated with this. They're trying to deflect, and they don't want to reveal that they have memory loss. And so if I have a patient that's just getting too agitated as I'm going through the formal testing, then I'll just try to engage them in a conversation about something they're interested in. So if they're really big Los Angeles Lakers basketball fans, well, we'll talk about the Lakers. I mean, it has to be something you know a little bit about, but ask them who plays for the Lakers. And if they can't even remember, LeBron James, then obviously that would be significant. So an MRI will reveal atrophy, and especially we're going to look for atrophy of the hippocampus. Other tests that are done mainly for research purposes, we can do metabolic tests such as PET or SPECT studies, which would show hypometabolism, especially in the temporal parietal areas of the brain. And something that will be really very useful if this is ever routinely available are PET amyloid imaging, where we can actually, by PET scan, visualize the amyloid. Okay, and then of course at autopsy, then we can confirm the plaques and neurofibrillary tangles and all of that. So here's an MRI scan just to kind of show a healthy adult brain and just notice the significant atrophy. So this is what we would see. Look at the sulci, very large. Okay, but most useful of all here, if we can do a coronal section of the hippocampus. So here we're looking at the temporal lobe right here. Here's a healthy hippocampus. All right, and notice here the big temporal horn of the lateral ventricle with a very small hippocampus. So if you do an MRI and someone with mild cognitive impairment and you've seen this individual is guaranteed to go on and have Alzheimer's. well, they really do have Alzheimer's already, even you're just picking it up at a very early stage. So here's another picture here showing you kind of a healthy hippocampus. Here's in white, you can see the temporal horn of the lateral ventricle, and notice how much larger it is here. Okay, so this hippocampal atrophy is what's seen in Alzheimer's. So I mentioned on the PET scans, we can see hypometabolism, which is seen here in blue, here at kind of a temporal parietal junction. And we can image here for amyloid, which shows up in red. Okay, so this is very useful, especially for research studies, and there's a lot of push to get this out and available for just routine diagnosis of Alzheimer's dementia. There's a lot of interest in many studies here over the last 5 years looking at monoclonal antibodies developed against amyloid plaques. And so this was done at least 3 or 4 years ago, but look at all the amyloid here at baseline. Okay, and now we give this medication, which I won't ask you about, but I'm just kind of making a point here. And look how much we can reduce the burden of amyloid in the brain compared to placebo. Now, unfortunately, there was really very little clinical benefit, even though we virtually eliminated the amyloid, and probably that's just because there was already so much destruction of the brain already in this process. And so there is some investigation if we can maybe pick up individuals at a pre-symptomatic phase, that then we might be able to intervene in all of this. Now, if we just look at biomarkers here, one thing that's amazing, just like with Parkinson's disease, patients are developing Alzheimer's more than 10 years before they have onset of symptoms. All right, so we have a normal individual here. We can just kind of look at things like tau begins to increase, amyloid begins to increase. These two kind of happen together here. And then PET scans actually can pick up this amyloid pretty early. So patients not as years away from being symptomatic. MRI, we can detect some of the atrophy. That would be a pretty early feature. And if we do formal cognitive testing, again, we could pick up some problems here at a pre-symptomatic phase. And here we are with a patient with mild cognitive impairment. Okay, so again, even though we say, well, this is kind of an early pre-Alzheimer's stage for most patients, a lot has been going on for years before patients reach that stage. All right, so it would be very important in anyone that's having memory loss, we do a detailed neurologic examination, and certainly if there are any focal findings, it would be extremely important that we do an MRI scan of the brain to look for any mass or stroke or something like that. We always do a metabolic workup, so any abnormality here could contribute to cognitive dysfunction. So we do a full chemistry panel to look at electrolytes. We want to do a complete blood count, liver function, B12, thyroid studies, a urinalysis, even a bladder infection in the elderly could present just with some cognitive dysfunction. So in general, most patients die within 6 to 12 years of the onset, but the range is wide. I followed for more than 10 years a pediatrician who had Alzheimer's, and he lived with this for well over 15 years. So the range is broad, but this is kind of a big picture. Now, in terms of treatment, there are 3 FDA-approved acetylcholinesterase inhibitors. Now, this is different than pyridostigmine, which mainly acts peripherally. These medications mainly act centrally in the brain. They do have a little bit of a peripheral effect, but it's mainly centrally. And so the 2 that I would like you to know, the highest yield for boards would certainly be donepezil, but rivastigmine is another one to know because we're going to come back to this medication. So know these 2. Galantamine is one that I won't ask you, but it is another centrally acting acetylcholinesterase inhibitor. All right, so again, we have a cholinergic deficit in Alzheimer's. So these medications raise acetylcholine a little bit. Acetylcholine is very important for memory function, and so it has a mild effect for patients. It has no healing properties, but it can improve memory function to a modest degree. So because we do have some peripheral effects on acetylcholinesterase, you get a little more acetylcholine stimulated in the GI tract. That's going to cause stomach cramps, diarrhea, nausea, and vomiting. Those are probably the most common side effects that we see with this class of medications. Now, when we're in a moderate to advanced stage, we really don't have good evidence that these acetylcholinesterase medications are helpful. And so now we consider the medication memantine. And one theory of Alzheimer's is that glutamate, which remember is the main excitatory neurotransmitter in the brain, that through excessive stimulation of the NMDA receptor may have some toxicity to neurons. And so memantine blocks the release of glutamate, so it's considered an NMDA receptor antagonist, and through that mechanism it has a slight effect of slowing cognitive decline. Again, very, very mild benefit, not a dramatic benefit. And also just really important that when we have someone with Alzheimer's that we're aware, especially in the more advanced stages, how common depression, delusions, and psychosis is. So we do want to treat those. And I would say neurologists, again, because Parkinsonism is common in advanced Alzheimer's, we try to avoid medications that block dopamine, so we consider an atypical neuroleptic like quetiapine, which isn't going to have or isn't going to contribute to Parkinsonism. All right, so we don't have any proven benefit. Lots of people use these things like ginkgo biloba, but these have all been studied. And just go to your local drugstore and look at all of the over-the-counter things that can be tried for memory loss. All of those are unproven. Okay, but with anything that is common and disabling, patients are going to, research and try to find things on the internet that can help. So you do need to be aware and tell patients what isn't helpful, so that a lot of money isn't spent on things that are unproven. All right, so next time we'll get into the differential of dementia, starting with multi-infarct dementia.